Hi guys, Laura here, medical oncology nurse practitioner. Just to give you a quick update, brief overview of hypercalcemia of malignancy. Okay. So to this presentation, we'll look at definition and causes, the symptoms and diagnosis, and treatment and hopefully prevention. So we'll go on and have a chat. So hypercalcemia is actually defined as a serum calcium of 2.6 millimoles per litre or greater than the upper limit of normal. So that's actually corrected for albumin, and this is done on the pathology. There are calculations out there that you can use, but it's quite complicated and I wouldn't really recommend it. I think the best thing to do is look at your pathology and actually look at the corrected calcium and go from that. Pathology, most labs will give you a calcium plus a corrected, and it's a corrected that you want to be looking at. Normally, therapy for hypercalcemia, especially within malignancy, is initiated for patients who are symptomatic with a serum calcium concentration of 3.0 millimoles per litre. So the mild range is 2.6 to 2.9, moderate is 3 to 3.4, and severe is over 3.4. And this is actually considered a medical emergency and is normally treated immediately and aggressively. So look out for your patient's blood. And serum calcium is just looking at the blood level of calcium. So normal pathological process is that parathyroid hormone is secreted from the parathyroid gland when it realizes that there's a low level of calcium within the circulating blood. Then parathyroid hormone travels to the bones and it binds with receptors on the osteoblasts, and they're the bone building cells. And this actually increases expression of the rank ligand, and that then binds to rank, which is on the osteoclasts, which is the bone reabsorbing cells, which increases their activity and the calcium reabsorption and increased serum calcium levels in the blood. So that's the normal process of how things happen with the calcium. Calcium is normally transported in the blood and it can be bound to albumin. And that's where we get our corrected calcium from when we look at the calculations. And it can also be free, and that's a normal range of 2.25 to 2.65, and that's lab dependent. And the levels within the blood are tightly controlled within negative feedback within the parathyroid hormone. So calcium is an essential cation, which is basically another word for a positively charged ion, which circulates in the blood. And the Ca2 plus means that the 2 plus refers to the ionic charge of the calcium in its most common form. And it has those 2 electrons that are available for binding, which it loses when it binds. So it plays a pivotal role in various physiological functions, including it regulates myocardial activity, nerve transmission, vascular health, intracellular signaling, hormonal secretion, and mineral balance. And it actually requires a really tight regulation for homeostasis, and it's accomplished via the kidneys, bones, and the GI tract. And other examples of cations in the body is like sodium, potassium, magnesium, iron, etc., stuff like that. So total calcium is calcium that is the overall level within the blood. About 40% of the calcium in the blood is bound to albumin, and the rest is ionized. And that just means that it's free to within the circulation and it's available for use. Corrected calcium, as mentioned, is the calculated measure of actual amount of calcium available in the body, and that's where it's collected for the amount that's actually attached to albumin, and that will then affect the overall total calcium. We look at the true serum calcium in the body, and then we account for the effect of the amount actually bound to albumin, and that gives us that corrected value, and it really helps in an accurate assessment. Sorry, that was just a quick calculation that I've found on how to calculate a corrected calcium level on someone's pathology. There's an example there, but as I've said previously, I wouldn't advise doing it independently. It's not something that we normally do. It's there within your blood results that come from the lab. So hypercalcemia of malignancy can actually affect around 30% of all cancer patients during the clinical course. Whether it be hypocalcemia or hypercalcemia, it can actually be detrimental and can cause acute and chronic effects on the cardiac tissue, renal system, and the bone health. Normally, hypercalcemia of malignancy is asymptomatic, and it's actually found on pathology results. And it's just most common in the highest prevalence is within multiple myeloma, breast, renal cancer, lung, especially squamous cell and lymphoma. However, as cancers progress and can be aggressive or more advanced, there is a higher chance of a patient actually developing hypercalcemia. Hypercalcemia is not just in malignancy. As we know, patients can present with it as well, but our patients will be malignancy. It may not be the causative factor, though. There can be other. So this is just a little mnemonic, which is not actually malignancy specific. So double checking when patients come in, are they on calcium supplementation? Pathology will show you about the parathyroid gland and its secretions, and is it higher, and being the causative factor. The iatrogenic is immobilization, prolonged bed rest. Can cause it. Multiple myeloma, there is a milk alkali syndrome, which is a triad of things, which is hypercalcemia, normally from ingestion, like antacids, then a metabolic alkalosis, which is a impaired pH balance in the body, and then they also have an acute kidney injury, so something going on with the kidneys causing them not to eliminate, get rid of the calcium. Then we have like parathyroid hyperplasia, where the glands of the parathyroid, there's 4 glands, and they can become enlarged and a little bit more overactive, and they actually excessively excrete parathyroid hormone, causing elevated levels in the blood. Alcohol can cause it as well. So that affects the liver, which can reduce activation of vitamin D, which is essential for calcium absorption. So that can happen as well. It can interfere with the bones as well if someone's an alcoholic, unfortunately. Neoplasms, as we know, that malignancy can cause it. Zollinger-Ellison syndrome, which is gastrin secreting tumors or gastrinomas in the pancreas or the duodenum, and they increase secretion of gastrin, which increases acid secretion and peptic ulcers, and they can also be associated with MEN1, which is a genetic disorder which can include tumours in the bodies and the endocrine glands. And excessive vitamin D, which can actually increase calcium absorption. Excessive increased vitamin A increases bone reabsorption. And another condition in the general community can be sarcoidosis, which is the development of granulomas, little benign tumors or little growths in the lungs, and they create an increased 1-alpha hydroxylase activity, which is an active form of calcitrol, which ends up converting vitamin D as well, and that can cause more absorption in the intestines, leading to elevated levels as well. When we're looking at malignant hypercalcemia, there are a few reasons behind that. From its own thing, malignancy, as we've said previously, can cause it. Neoplasms, malignancy. But there can be humoral hypercalcemia of malignancy, which is caused by too much parathyroid hormone related peptide secretion, and that can be associated with stimulation of osteoclast reabsorption, and it inhibits osteoblast formation of bone, which increases calcium release from the skeleton into the circulation, and there's reduced clearance from the kidneys. The local osteolytic hypercalcemia, which is caused by decreased mobility due to cancer or cancer attacking the bone, and that can cause release of cytokines and chemokines, and increasing osteoclast activity, and again reduce clearance from the kidneys. And then we have calcitriol-mediated hypocalcemia, normally associated with lymphomas when there is when again there's overexpression of the 1-alpha hydroxylase, the enzyme responsible for converting vitamin D to calcitrol, which ends up having an excessive production of the calcitrol, which is actually the active form of vitamin D, and that causes increased absorption intestinally and increased osteoclast activity with enhanced renal retention, so that renal effect again. And then we can have ectopic hyperparathyroidism, which is normally due to a tumour on the parathyroid, which is increasing the secretion of that parathyroid hormone, and that's a little bit more rare. So symptoms, what would you expect symptoms patients to be experiencing? Well, a little mnemonic again. We've got the stones, bones, thrones, groans, and tones is what I was always taught. So there's several things that can be going on in the body. We can have the generalized fatigue and muscle weakness because of the discomfort and the pain and the tiredness as well that can happen. We can have patients who end up having kidney stones, they can get gallbladder stones, they can get bone pain, they're normally constipated. And have that muscle weakness, so that discomfort, the groans. They're polyuria, so they're definitely frequently urinating because the body's trying to excrete and eliminate that hypercalcemia via going to the bathroom and that urinary release. And then there can be psychiatric, the overtones, that's depression and confusion, and that can happen a lot as well. They can have that lack of mental clarity, they kind of find it difficult to concentrate and think clearly. That's some other common signs and symptoms again, which is on EVIQ, and they actually have a module for staff to go on and do, and it's really helpful. It just runs through everything again for a bit more understanding. This was just a little table of the mild, moderate, and severe symptoms that can happen and what organ function it can happen with. So, like mild hypercalcemia, they can have constipation and just off their food. They can have a little bit of increased renal urine output. There can be a little mild confusion, a bit tired, maybe a little bit anxious or depressed in their affect. Musculoskeletal, they can get some bony aches and pains, and they can feel a little bit fatigued. But as you go through and the hypercalcemia becomes more severe, the symptoms actually start to become a little bit more serious and more noticeable within a patient. So they will be experiencing more symptoms and just maybe not as well as what they were previously. And just to remember that mild is 2.6 to 2.9, moderate 3.0 to 3.4, and severe is over 3.4. So we'd want to be looking at starting treatment about that moderate. So the diagnosing, quite like a lot of things within our population, it's multifactorial. So not only will the patient present and can be quite challenging to try and rule out or rule in what's actually going on with them. So it takes a lot of time and effort to look at the patients and understand what's going on. So what they're complaining of, or sometimes what the family members are actually expressing and telling you is going on. So that's always good to keep that in mind, because if the patient is confused or disorientated slightly, they may not actually know what's going on or how long it's been going on or what it started with. And especially if they present in pain, that's another thing that can make them a little bit cognitively defected as well. So looking at that, there's signs and symptoms like we spoke about on the earlier slide, the moans, groans, tones, thrones and stones, but also looking at blood levels. If you are suspicious for a hypercalcemia, then definitely make sure that some bloods are done to include that CMP, that calcium, magnesium and phosphate, because it will, as I've said earlier, give you that corrected calcium, so you actually know what calcium level you're dealing with. Sometimes we have to image a patient to understand what's going on, do some additional scans to see, is it coming from the cancer or is it not? Is there actually something going on in the parathyroid? What is the underlying cause? And you may never find the cause, but you may know that it's coming from malignancy, so that may just be the cause. There may not be anything else. It may unfortunately just be the disease. There can be ECG changes as well within hypercalcemia, like a lot of electrolyte imbalances within our patients. So making sure, if you are suspicious, that an ECG is attended, because they can have a shortened QT interval. They can have a J wave, which is also called an Osborne wave, and that's a little notch at the end of the QRS complex. They can have ventricular arrhythmias because of that irritability on the cardiac muscle. They can actually eventually become ventricular fibrillation, so be mindful. And they can have a shortened PR interval. There can be T wave amplification and a widened QRS complex. So have a little look at an ECG. So treating, what do we do? Well, depending on the degree or the severity of the hypercalcemia and where they are, if they're in the outpatient setting, they may be able to have some meter, some fluids, and go home with a recheck of their pathology. If it's a little bit more serious, then obviously if it's moderate to severe, they may have to be admitted, unfortunately, for a little bit more aggressive therapy. So obviously medications, we want to look and stop and see if they're on any calcium supplements, vitamin D supplements. The thiazide diuretics and antidepressant lithium are quite notorious, but also we have to make sure that we're also looking at medications that can actually worsen the renal function. Are they actually holding on to the calcium? So have they suddenly started taking non-steroidals or a new ACE inhibitor, and their renal function's not as good as what it was, and they're not actually managing to void that calcium? If they've got pain, then we want to look at analgesia. What can we give them safely, depending on the rest of their blood test results, to make sure that we keep them as safe as possible. Antiemetics if they've got any nausea and vomiting, and laxatives, especially if they've got constipation. And we're looking at rehydration. We want to be protecting the kidney functions while hydrating and encouraging the kidneys to void or pass out as much calcium as possible. So we normally look at giving 3 litres within 24 hours if there's no comorbidities or contraindications. And that's normally when we're in the moderate level, and depending on patient symptoms also, but we'd want to be looking at rehydration. Again, we'd be wanting to look at giving treatment with bisphosphonates, so like our Zimeta, and then maybe they may already be on something at home, but we need to look at what else we have to do as well, because some of our older population may already be on alendronate in the community for their osteoporosis, so we want to double check, because if they are, then they'll be on a calcium and vitamin D supplement normally, but they may not be, but you'd want to be double checking that as well. We used to give pamidronate, but it's not used as much now, but normally the go-to drug is zoledronic acid or Zimeta. Surgery, well, that's really if it's coming from a parathyroid hormone coming from that parathyroid gland. Is there any role in removing that or the thyroid? What is the patient's diagnosis, prognosis, ECOG, how good are the comorbidities? Are they fit enough for any surgeries like that? But that's definitely for the medical team. For us, it's looking at just getting everything started and trying to alleviate some of the symptoms immediately and take it from there. So, little quick overview, the bone remodeling system, which normally actually takes around 120 days for all of this process to happen, is quite informative for when we're looking at what happens to the bones and when we give the medications as well. So we've got our osteocytes, then we've got our resting phase and the reabsorption where the osteoclast is looking at reabsorbing old bone, breaking it down. Then we've got the reversal where we want the osteoblast to build the new bone within the formation phase and then to strengthen the bone. And then we go back into resting phase and then we go back through it and we do it all again. So that's that. So Zumita is actually a third generation nitrogen containing bisphosphonate, which actually inhibits osteoclast function, those reabsorbing cells, and prevents bone reabsorption. So this in turn leads to increased bone mineral density and reduced bone turnover. It actually binds then to the osteoclast, which leads to programmed cell death or apoptosis. So it's given as an intravenous infusion. It's normally given monthly, depending on the indication. It is PBS listed for hypercalcaemia of malignancy, and as it says there, it inhibits bone reabsorption via the action on osteoclasts. It is renally cleared, so we have to worry about the dose if we have a change in someone's renal function, and that's when you need your pathology results to be reviewed. Any issues with it or side effects, normally mild and transient for about 24 to 48 hours, including the flu-like syndrome, bone and joint pain, headaches, the GI problems, local reactions, and rarely we can get that osteonecrosis of the jaw. And if used on a longer term basis, we have atypical femoral fractures, and that's something that we need to counsel our patients on. But onset of effect, so its maximum effect is up to 4 to 7 days, so its half-life is 146 hours, so it stays in the body for a while. The duration of effect is up to 4 weeks. So we do want to talk to patients about the changes that can happen. So we can have a hypocalcemia, so we can reduce that calcium, the effect we look for, but to the point where we can make it a little bit lower than we would like. We want to talk about osteonecrosis of the jaw and any other toxicity in the risk profile that to discuss with the patient. So it's normally very well tolerated. It is given with fluids, as we've said about that rehydration as well, and it's normally very effective. However, if it isn't effective, there is another drug. So we've got denosumab as well, which, as I've said, is another option. However, it's not PBS listed. So I've seen it used a few times when Zumita hasn't been effective, which isn't that often, but does happen very infrequently. So denosumab is fully humanized IgG2 monoclonal antibody. It works by targeting a protein called RANK ligand, which is on osteoclasts, and it actually controls the activity of them. It stops them as breaking down or reabsorbing that bone, and it actually strengthens the bone. So it inhibits the interaction with RANK, as we said, on the osteoclast, prevents the formation, function, survival of osteoclasts. leading to that significant reduction in bone reabsorption and an increased bone mass and strength. It's a subcutaneous injection. It's given as Prolia, which is 60 milligrams, or Xgeva, 120 milligrams, which is normally what we do on a monthly. And then we can look at the frequency depending on the patient. Prolia is normally given for osteoporosis in the community. So its maximum effect is roughly about 10 days. That can range from 3 to 21, and its concentration declines over 4 to 5 months. So its half-life is about a month, 32 days. So it does have some side effects like injection site reactions. It can cause musculoskeletal pain. It can drop the levels of calcium, so a hypokalemia, the risk of osteonecrosis of the jaw again, and there is an increased risk of infections because there's immune modulation, because rank ligand has a role in the maintenance of the immune system. So it can actually affect the selection of T cells within the body. So it's quite effective. Considerations. What do we do with a patient with hypercalcaemia of malignancy? Well, the management can be quite complex. It can require a few multidisciplinary team members and approach because of the nutritional support we need, the pain management, a lot of psychological support, and we're really looking at improving the quality of life of patients with this condition. So we want to be doing a thorough assessment when they come in. So you want to be looking at all systems as we do normally. So top to toe, what's going on with the patient? How is their confusion, disorientation? Are they confused, disorientated, or is this their normal? Is it any worse than normal? What's the difference? What's going on with them? And then have they got any pain, discomfort? What are we looking at? We want to be looking at the other medical history. What is the diagnosis? Are they, depending on the area that you work in, are they a general patient, a surgical patient, a medical patient, cardiac patient, or are they actually a cancer patient, one of our patients known to us? We want to look at the medications, including over the counter. Don't forget them, because they can be crucial. They kind of started something from the GP, the naturopath, any other practitioner that they see out there in the community. So we need to know what they're on, what they're taking, the dose, everything as well, so we can just make sure that's not a contributing factor. We want to look at vitamins, herbals, supplements, recreational, everything as well. And we want to look at physio referrals to get them up and moving if they're not, if it's safe to do so, a dietitian, because hypercalcemia can reduce the smooth muscle contractility, and they can get poor GI motility and emptying. That's why they get constipation. So we want to be looking at what they're eating and drinking, and a food and fluid chart would help with that, and getting them up when they're fit and able to do so with a physio is ideal, and then able to mobilize as able. We want to look at the neurological system. There's decreased excitability of the neurons and impaired electrical conduction and cell membrane permeability. So that's why they feel fatigued and lethargic, a bit more confused. They can end up developing psychosis, but they can also become comatose as well, which is really horrible if that's what happens to them near the end, because that means that we are not able to, sometimes we can't treat it, and the morbidity is high, unfortunately, if we don't get on it early. We've got the renal system as well to think about. So that interference with the renal collecting tubules that happens, they cannot concentrate the urine, they have volume loss, and then they have a reduced glomerular filtration rate. So they can become dehydrated, and they can get itchy skin because they've got that retention happening. They can have cardiovascular problems because of impaired electrical conduction and that cell membrane permeability. They can develop atrial vasocontraction, so they can have bradyarrhythmias, they can have asystole. So it's quite important for that ECG to check for arrhythmia on admission. We want that strict fluid balance chart because we want to know what's going in and what's coming out. Are they in retention? Are they not being hydrated enough? Do we need to give them more fluids if it's safe to do so? And then we want to make sure that we're IV access, so we can give the infusion of Zamita, the 3 litres or 4, whatever litres of fluid we have to give, depending on pathology, and repairing that pathology again. Just check on that parathyroid hormone if required, but also that CMP and the UECs. What's happening with the calcium? Is it coming down? What's happening with the kidney function? Was it bad? Is it improving? Is it stable? What's actually the actual picture that's in front of you? That IV access is also there for emergency if anything does change with them. So it's really good to make sure that that's there and patent. And really to talk to them about a dental review if they do receive a bisphosphonate, which they probably will, or that rank ligand, just to make sure that they have that done if they are eventually discharged home, that they have some sort of dental follow-up just to give them that clearance for when they actually get home. Questions, well, you can email questions to me, laura.haley@calvarymatter.org.au. I'm happy to take suggestions on any talks, anything you'd like to know if I don't know, because I don't know everything. Definitely happy to try and help you work it out, or look at getting some answers for you, or finding some literature, or anything else that you'd need. So please just reach out. You've also got the educators on the ward and in the day treatment centre as well, so please don't hesitate to speak to them. But if you need, then please just shoot me a little email. Happy to answer. If I'm not in, I'll put my out of office, so you'll know I'll get back to you as soon as I possibly can. Thanks for listening, guys. There's just a couple of references, a little bit about hypercalcemia and mediation. Is it non-PTH, PTH? And then just a little look at a case study that's happened previously. And don't forget to look at the EVQ online resources as well. There is a module for staff to do to look at hypercalcaemia of malignancy, as well as other modules that are really, really good and helpful and effective. All right. Cheers, guys. Take care.